This is the sixth and final narrated PowerPoint that you'll be getting as part of the Nebraska Quality Improvement Project. Don't get too excited. I know that you're probably tired of having all of these, but I hope they've been useful to you. And I want to spend the last hour of time talking about particular patients. We all in our practice have two groups of patients that I want to talk about. Those who are challenging for any number of reasons. We might label them difficult patients. And often the ones who numbers are so bad that they mess up our averages. This is the type 2 diabetic who we can't get an A1C below 11, or a hypertensive patient who we can't get a blood pressure below 180 over 120. And for some other reasons are challenging. But another group of patients that I suspect some of you are working with are those that we would call the vulnerable, which are usually people who are a subset of the population who have vulnerability for a variety of reasons that we'll talk about. So that's what we're going to talk about this last hour, and I hope you find this information useful. So to be official with regard to the quality, or to the CEs, the objectives are that we're going to identify patients who are most challenging, but also patients who are vulnerable or at risk for poor health outcomes. And we're going to describe some components of what I call intensive primary care as a strategy for assisting either challenging or vulnerable patients. We're going to focus particularly on a model called the 5 A's as an approach to dealing with challenging and vulnerable patients. And we're going to very briefly, not spend a lot of time reviewing self-management support strategies as a means for improving patient outcomes. And I do hope that you still have those notes, and we'll go back and use those as tools for this intervention model that we're going to talk about. Vulnerable patients are usually a population of patients rather than individual patients. They often have low health literacy, although truthfully, when data are explored from the entire population of people in this country, most of the people in this country would be defined as having low health literacy. But these are often people who are also semi-literate, and that's a problem that's different from health literacy. We have good data to suggest that people who are from a lower socioeconomic status, that means either they're poor or they have low income or both, who are uninsured, who are not fluent in English, and who are members of minorities, are at greater risk for both poor outcomes and disparities in their health care. But the other thing that you all live much more closely to than most people is the fact that living in a rural setting is also a risk factor to being a vulnerable patient. All of these are factors that are clearly associated with poor health outcomes, but I think more importantly, the receipt of poor quality health care. They're more likely, for example, not to get mammograms or pap smears, not to get their immunizations. All sorts of markers of quality care that need to be taken into consideration when we're doing quality improvement. Now, challenging patients are different. They may not have the characteristics of vulnerability, but they are difficult. They may be difficult for a variety of reasons that we don't know about, and we're going to talk about finding out why they're difficult as part of the plan. But they may have a personality disorder that has been undiagnosed. Not that you can do anything about it, but at least if you understand it, you can work with them more effectively. They may have undiagnosed literacy issues or any number of other factors that make them just difficult to work with. Whatever the cause, most clinics can identify who these patients are with a fair degree of accuracy. If you all stopped the CD right now and sat around and said, who are our difficult patients? My guess is that you would come up with the same half dozen people, all of you. So what works with vulnerable patients? And again, this is often a population of patients. Like in my practice, I have two groups of, well, three. I have three groups of patients, all of whom have characteristics of vulnerability but are some way differentiated, mostly by their culture. The three strategies that, based on research, are known to be effective and that you should incorporate into your quality improvement program are case management. We're going to talk about that. I know that you don't have a case manager just sitting there in your clinic probably. And then cultural sensitivity that's incorporated into your quality improvement, and then what is called multi-level interventions. And again, this may be a duh for some of you, but it's the idea that we involve the individual and the family, but also communities in working with groups of vulnerable patients. And I'll give some examples in a couple minutes of some things we're doing in the Galveston community. So from now on, I'm going to be talking about individual patients generally, but these are from a population of patients that are at risk. In my community, a good example is the African American community with a high prevalence of uncontrolled hypertension. But I also have a large population of patients who are Hispanic, who are not English, non-native English speakers, who have diabetes, who are relatively new immigrants. But I have a very diverse patient population. I also have a large number of Anglo or white patients who are just poor and have lived in poverty all their lives, have lived on the margin, probably low levels of education, and have lots of other barriers to being members, effective members of the community. You may have a Native American community with a high prevalence of poorly controlled type 2 diabetes in your patient population. So there are any number of groups, but I want you to notice that most of these are associated with a cultural component. And it's important here that the quality improvement for these vulnerable populations include multiple types of interventions concurrently. So you just don't say, okay, this is an African American patient with uncontrolled hypertension, and do one thing for her. You have to think about your community of patients who are African American with uncontrolled hypertension. And so you think about what you're going to do for the individual, but also what you're going to do for the community. The same with any other subset of patients that you're working with. So let's talk about case management. These patients should, whenever possible, have a case manager. This, of course, is an individual, or you could call it a family-level intervention. The concept of case management can be tweaked in any number of ways. You could have a peer health coach, a visiting nurse, a nurse case manager, or very common, at least here in the Southwest, programs that have promotores. In the Native American community, it's very common to have peer support groups, so peer educators or peer support people. It doesn't really matter how you tweak this particular concept. The role involves several core characteristics. One is that you have one-on-one personalized coaching and patient education, usually from a member of the community, but if not a member of the community, somebody who's working close with that patient. There should be home visitation involved. It really makes a difference with difficult patients to just go visit the home, talk to other family members, get a feel for what kind of circumstance the patient is living in. And these are data that will be very helpful as you move forward with improving their health. And this person helps these patients with health challenges that we just don't always have time to do. Helps with filling out pharmacy assistance forms, help with making appointments with specialists, helps with getting them somewhere, finding access to care. And then finally, advocacy, speaking out for the patient when necessary. But on the other side of that, reinforcing what the provider says. I'm very blessed in my practice to have 3 case managers from another program who 70% of their patients are actually primary care patients in our clinic. And it's very common for the case manager to come to the clinic, visit with the patient, and be in the room with the patient. And so we have a triad. There's 3 of us there, the patient, me, and the case manager. And so the case manager can speak and help the patient to advocate for what their needs are. But the case manager is also hearing what I am saying and can reinforce this. And I just really love the fact that then I get feedback from these case managers and know how things are going. I can get a picture of what their circumstance is. It's just a wonderful partnership that I find invaluable in working with my very vulnerable patients. There are other case characteristics based on the model of case management and the patient's particular need. But the bottom line is that case managers work with vulnerable patients at risk. Another good example, I'm noted pregnant women here, but for example, if you happen to be familiar with the Nurse Family Visitor program, Partnership, I think it's called. It's a wonderful program that's really gotten a lot of spread nationally, where nurses are partnered with high-risk pregnant women, young women. By the 26th week of pregnancy, they have to develop this relationship. It's highly structured. They work with them for over 2 years. But the amazing thing is that they've done this with many, many, many women across the country with all sorts of different populations. And they have long-term data that are just amazing about the outcomes in terms of the health of the child, the health of the mother, things like, you know, the mom is working, the mom has had fewer unplanned pregnancies, the child's not in jail, any number of things that are amazing outcomes from this investment in a case manager. Now I am not a mind reader, but I can guess that you all may be asking, well, where do we find a case manager? How do we get one? What do we do about this issue? Because your resources are limited, and I appreciate that. Well, first of all, you can look around the room. Your nurse or your nursing staff is probably already doing this. In fact, I'm sure they are, and the role just needs to be more formalized. The nurse needs to be offered perhaps some additional training, and there needs to be time set aside for this work. It needs to be in the nurse's role or whoever you choose to make the case manager, and they need to have time set aside for doing this. But there also may be resources in your community. A visiting nurses agency, probably not, but there might be something. If there's any chance that you're somewhere near the School of Nursing, for example, if you're anywhere near Carnegie or Scottsbluff and can get in touch with the community health faculty out there, they could involve their students in this. We do this. Our community health students do case management in a med student clinic that we have on Tuesday and Thursday evenings. And the med students just wouldn't have clinic without the student case managers. They find them so important. So it's a win-win. The students are winning, they're accomplishing something, they're learning something, but the patients are benefiting too, and you're getting it for free. If you have no resources at all, you just don't know where to go, but you recognize that you need this, you might talk with the people of the state involved in this program, or the county extension office often has somebody who can help in finding somebody who can help you find a case manager to fill this role. It's going to be well worth the investment. I'm not going to go any further into this, but I think you've got the message about how important I think a case manager is in having access to somebody in that role in your practice. It doesn't have to be in your practice. It could be a partner in the community, somebody you can pick up the phone and call and say, hey, you know, I need you to make a visit to this patient. I'm going to refer this patient to you for home visitation. The second aspect of evidence-based for quality improvement, or for care of vulnerable people populations, is this culturally sensitive quality improvement. Now, you're already doing quality improvement, we know that, but this is a population level intervention. If you have a significant number of vulnerable patients from a different culture in your practice, this would be a good idea to get involved in. Now, if you don't, and I've done some research out in central Nebraska and seen the data, and you may very well not have a subset of a different culture in your practice, but you may very well. So if you do, one of the things you want to do is get them involved in your quality improvement work to make sure that you're meeting their cultural needs. And so it would be a very good idea to invite a member of the community to be a member of your quality improvement committee. You may have already done this, but on the off chance that you haven't, it's something to consider. There are, of course, a few rules. It really should be somebody who's a patient in your practice, representing your practice, not the community per se. I mean, they're representing the community, but they should be a part of your practice because they should have that kind of commitment to the quality. And then, of course, you have to remind them about patient confidentiality and make sure they sign the HIPAA forms. Now, once you get this person on your committee, you should listen to them. They should be important, and what they say should be attended to. Just an example in my practice, again, I recently, I guess about 6 months ago, my staff contacted me and said, you know, we really need to change our hours. And many of my staff are members of the community in which they serve. And they said, you know, we just don't have any patients in the afternoon. They all come in the morning, and we really want to push our hours down to early morning hours and then stop seeing patients in the afternoon so that we have time to work on the case management and stuff like that. Now, I had come from a practice in Nebraska where, frankly, nobody ever showed up for an appointment before 10 or 11 in the morning, and, you could have clinic until midnight and people would still show up. So I was a little shocked, but I did listen to them and said, sure, if you think that's what's going to work better for this patient population, then I'm all for it. And they did that, and it's worked very well. So do listen to them. Don't say yes, but, or it's not been my experience, or how's that going to work. Figure out a way to do it. And then a concept that I want to bring into this is the idea of cultural leverage. I think this is a great concept. And it goes back to community resources. And again, you may be in a community that doesn't have the resources for this, but if you can, or if you can develop it, these are finding culturally sensitive resources for your patients in the community. And this is as simple as a diabetes education class in Spanish, or, for example, an exercise class that's based on African dance for African American people, or in the Hispanic community, a salsa dancing class. Or if you're a masochist like me, I got Zumba recently, which is salsa dancing, and got those CDs and have been working on that. And so you might, invest in the Zumba CDs and see if you could get a class going in your neighborhood using those CDs. I haven't gotten beyond learning the steps, and that's enough aerobic exercise for me, but then I'm old. So eventually I'll get to the rest of the CDs, but that's a nice exercise with a very Latin Hispanic flavor, and it's really very good exercise, trust me. The final piece related to vulnerable populations is this idea of a multi-level intervention, and we sort of talked about this, and of course in some ways this is a natural part of a small community, and the idea is that your patients do better when their family and community are involved in the health issues that are challenges for them. So for example, we recently did a community assessment with a group I'm involved in, and they went out and just talked to members of the community, had open groups, and it's in a process called, I can't remember what it's called, forget it. But anyhow, they came up with two very interesting things. Number one, that the community felt like they didn't know where people could go for care when they didn't have money and insurance, which says to me that my practice wasn't doing a very good job of marketing, and we actually didn't market at all, and so that would explain that. But the other thing that came out of that was how important faith was in the community that they were dealing with, and this is mostly the African American community. And that's been my experience in previous times that I've looked at community support systems in the African American community. It could very well be true in the Hispanic community too. But here in Galveston, what we have done is many churches are involved in health-related activities for their members, and so just meeting with local pastors and community leaders and see what you can do to get the community involved in issues that are important to the community, such as diabetes or hypertension or getting enough activity. Or it could be about the youth and drug problems. You know your communities better than me, and I tend to think in terms of diabetes and hypertension, but you could have other problems that are much more important. And there is no community that doesn't have the problem of not enough activity and too much eating and obesity. That is pervasive, and so anything you can do in your community to address the obesity epidemic through walking programs and exercise classes would be very beneficial. So now I'm going to move to challenging patients, and I'm using the term challenging. You might think of them as difficult patients, whatever you want to call, but this is a comprehensive intervention that will work. Now, when you hear it, this is an intensive intervention, but hopefully you don't have too many challenging patients. And what I'd really like you to do is to identify a few challenging patients and make a commitment to really working on trying to get this intervention going with just even a few patients. And when you get positive feedback from the patient and from the data, then that's going to just reinforce this model and make it all of a sudden you're going to say, hey, this really works, let's keep on doing it. At least that's what I hope. So as I mentioned in the transition slide, it's about 5 A's. And so the first A is ask, which is performing a comprehensive assessment. Now, think about this. When was the last time one of these difficult patients really had a comprehensive evaluation of their entire health history, their medication, their treatment plan. So this starts with you, once you identify these patients, is having them come in and spending some time, telling them to come in and to bring their brown bag of all their meds and all the doctors they're seeing and everything that they're doing, and try to get a comprehensive assessment. Again, if you've got student nurses around, this is a great job for a student nurse or a student nurse practitioner, but somebody who can perform a comprehensive assessment. And it's really, really much more a history than a physical. There may be some lab tests that haven't been done in a long time, and you want to do that. If there's a lot of meds, in a small community, sometimes you can just walk across the street to the pharmacy and leave the bag of meds and say, would you please look at these meds? What are outdated? What are interactive? Help us with this. You need to add a social assessment, and that means probably a home visit from the nurse, the case manager, somebody who's trained in doing a social assessment. What are your social support systems? Who visits you, takes care of you? Who do you live with? Do you get along with who you live with? There's all those kind of things. Also, the home assessment, is the home safe? And so you really need to look at these social problems and issues and the home issue. And then I strongly advocate for having a psychological evaluation. I use the word psychological rather than psychiatric. I'm not saying these people are mentally ill, but I am saying that there are problems that have probably never been picked up that may be informing why this patient's having so much trouble. They might be depressed. They might have learning difficulties. They might have a personality disorder. The list goes on and on. But the first thing you have to do is this really comprehensive picture. Just go back. You may think you know this person. My God, he's been in your practice for 30 years. But when was the last time somebody sat down and just really picked all of this information and put it in one organized place? So you'll learn a lot about the barriers to their successful health outcomes just from this. All of a sudden you'll say, oh, I didn't know that, I didn't know that. And then don't forget, as part of this assessment, to ask the patient what they believe are their biggest challenges to getting healthy. And then remember that you have to do something about all of this. Now, this doesn't mean that it's your job to take care of all of these problems, but you have to identify them. And then as a team, you have to figure out how to address them. There's a program that came out of Australia called the Flinders, F-L-I-N-D-E-R-S model. And it uses something like this. It's proprietary, which means you have to pay for it, and it's expensive, and those kind of things. But one of the big things they talk about at the beginning is that, you'd be surprised what the patient believes are their biggest challenges to getting healthy. And it's not remembering to take my meds. It might be taking care of my wife with Alzheimer's, or my son with cerebral palsy, or they might be depressed. There's any number of things, but get the picture. And again, don't not ask something. And I will tell you that providers traditionally will avoid going there, if you will, on some issues because they don't know what to do with it once they find it. So at this point, nobody's asking you to do anything about it, although you will have to. But get the big picture on this patient, and I think you'll find a lot of what's going on is coming out. But also, for heaven's sakes, don't forget that psych assessment, because there may be some somatization. There's any number of things. You really, really, really need this information. And work with the patient. They may have probably never had a psych evaluation. They're going to think you think they're crazy. It's not about that. It's about looking for all sorts of things, the way they think and how we can help them. So you figure out how to do it, but it really does need to be done. So that's the ask of the 5 A's. And far and away the most intensive, the most time-consuming, and the most important. So then A2, the second A, is advise, which is developing a comprehensive assessment plan, treatment plan. The clinicians doing the assessment should meet, and this is all of them. So you've got the nurse case manager, you've got the psychologist, you've got the nurse practitioner, or the PA, or the physician. They need to sit down and draft a list of all the health problems. These are not diagnoses. They may very well be diagnoses. Hypertension, uncontrolled, whatever. But there's problems too, like risk for, or uninsurance, or caring for a disabled parent. And so draft as long a list of health problems as you can. I used to tell my students when they go into my clinic and go do one of these comprehensive assessments on their patients that they don't come up with at least 10 problems and they don't have a sufficient list. And so remember, it's problems, it's not diagnoses, although there are certainly diagnoses in there. And then the clinicians should come up with a tentative treatment plan. Then the primary care provider, and this is really a primary care provider role, should meet with the patient and advise him or her about the conclusions and ask for input. Okay, here's what we identified. Here are the problems we identified. Here's what we think needs to be done. What do you think? Do you agree with this? Do you disagree with this? What do you think? What have we missed? What do you want to add? What don't you agree with at all? And then what are you willing to work with? The third A is agree. You have to reach consensus on a plan. The patient and the primary care provider have to come to some consensus on what they agree with as the final action plan. And the final problem is too, probably. And this is not your plan, it is the patient's plan, and so you have to negotiate this. At this point, it's a good time to start working with the patient on some self-management goals. For example, I'm trying to think of a good example. Something to do with their meds, or walking to the mailbox every day, some sort of goal that seems to pop out. And if you go back to the self-management support work, remember, ask them what their priorities are. And I don't think I mentioned that in that previously. What are the priorities, and what does the patient want to work with first? A patient has type 2 diabetes and they're out of control, but the problem is they've got the stress of taking care of the wife with Alzheimer's. Their priority is, I need somebody to help me with my wife with Alzheimer's, and I can't do anything about my diabetes until you all can help me with my wife with Alzheimer's. And so it may be that the case manager gets involved here in finding respite care as the first, and so working with the case manager on respite care, and then when the patient has respite, then he can use or she can use the self-management, that time, to achieve a self-management goal. The patient and the primary care provider should also agree on who is going to be the coach through this process. It's usually not going to be the primary care provider. This is just not in the scope of time and feasibility for the primary care provider, but it is a good idea to find somebody who's going to be their coach, because it's a fairly intimate relationship. This does not have to be the nurse. In my clinic in Nebraska, I trained my medical assistants, all of whom were bilingual and bicultural, to be coaches for my Hispanic patients. And, so whenever the patient came in, their coach and them and me, it was the three of us. And they weren't just translating what the patient was saying, but they were helping me understand the situation, and they were giving the patient advice and working with health education. And it was a very effective, and they were the ones that were doing the relentless follow-up that we're going to talk about in a few minutes. The primary care provider is the captain of this team and is the authority that's going to present this to the patient. But it's real important that the patient and you all understand that somebody else is probably going to have to be the coach and has to have the time for this role, which is where it goes back to organizational support. But it's going to pay off, and you have to figure out, by the way, talk to your billing people about how to bill as much of this as you can. The fourth A is to assist, which is helping the patients achieve their self-management goal. And again, this goes back to the coach, the case manager, doing regular follow-up, assisting with health education, problem solving, and implementing an action plan. Anybody who does research on self-management support and does the work will tell you that the term relentless follow-up is what makes it work or not. The patient is unlikely to take this seriously until you start calling him regularly and asking him or her how they're doing with their goals. And so they'll set some goals, and and they'll take that piece of paper home, and 3 days later you're going to call, and they're just going to be shocked that you called about this. And once they realize that you're taking this seriously, they're going to take this seriously. And so this relentless follow-up becomes really important, and this is where a case manager or a coach comes in, and it's also why it's terribly important that this person have time to do this. And again, you're only doing this with a few really intensive patients who you're having real challenges with. And so you might want to start with one patient, do a PDSA cycle with Mr. Jones, who's driving everybody crazy, and work this through. It's a pretty long PDSA cycle. It'll take a month just to get the whole assessment done and everything. But once you get this going, you will be shocked. You will be surprised. I once had a patient who was involved in all of this, and he was so, anxious to get back into what we were doing that he called from jail and wanted to tell us he was getting out soon and wanted to be sure and come back to his next visit. So I think he was just looking for somebody to talk to while he was in jail. But we won't go there. But they do get committed. The fifth and final A is to arrange special services. This may involve anything from arranging pharmacy assistance, smoking cessation classes, finding respite care for a spouse with Alzheimer's, appointment with a counselor, anything that the case manager or the coach determines would be useful for the patient. This is usually concurrent with assist, and during all of this time the case manager is working with the patient on small achievable self-management goals. Relentless follow-up. I think you sense a theme here. Relentless follow-up. If you are committed and continue to follow up with a patient, I can assure you the patient is going to be committed too, and you're going to really make a difference. Well, I think you can see why I call this intensive primary care. It requires a lot more effort than we generally put into one patient. But I think of this in terms of the 80-20 rule, and we all know that about 20% of our patients take 80% of the time. And in this model, at least you're controlling and structuring that time, and you have some tools that you can use to get positive outcomes with those patients, as opposed to what happens now, which is your sense of frustration and powerlessness and rolling your eyes every time you know that that particular patient is coming in. And what really, for those of us who really have no tools but are committed to caring for patients, becomes just a commitment to being present and listening to patients. But I've given you some tools and some structure that can be much more effective. This isn't for every patient. You don't have time to do this for every patient, but it will be an invaluable model for your challenging patients. And if you just try it for one or two people to start, I think you're going to find it really useful. And then you can just bring this model in when you need it. Not for everybody, but just when you need it. I'm trying to find that my mouse, there it is. My mouse isn't moving, sorry. In this session, I have reviewed two sets of strategies for special patient populations. The first are those vulnerable patients populations, which involves a combination of case management, culturally sensitive quality improvement, and getting the community involved in improving health outcomes. For challenging patients, the effort involved is what is called, I didn't name this, the 5 A's model. This is from another source. And it will pay off in improved health outcomes for patients, and I will tell you, a happier staff and clinicians. At least you feel like you've got some strategies rather than, I remember once being taught that the best strategy for these really difficult patients is to schedule them at the end of the evening, the end of the last day, patient of the day, so at least you're not late at the end of the day. I mean, golly, that's hardly the most efficient way. And yes, these patients need a lot of time, but let's make it effective time rather than just time being present with them. So thank you very much for the opportunity to work with you on this project. I know this is the last of the 6 continuing education offerings, but now is when we're really going to start connecting, and I hope to set up some time for some phone conferences and get back to your paperwork and your CEs and all of that, and we'll get moving on this, and so that you can make this work in your practices. And I know you're already working on it, but maybe I can help you out, and do feel free to contact me if you have any questions or concerns. Thank you very much. And I also want to say that I hope I can get up to visit you sometime.